Hello, I'm Dr. Fabio. I'm going to give you a lecture on COVID-19 experience and evidence-based treatment, 2001 update. I was a former chief of staff at two field hospitals in Brazil, and also an attending physician at a major university hospital. So this is my experience with COVID-19. It's very substantial, as I told you. I work at two field hospitals and I have seen thousands of patients, and I have been following all the development and the scientific and practical management of COVID-19. We have today the major variants of COVID, which have become very important for the pandemic development. And we have the British variant, we have the South Africa variant, the Brazilian variant, and now the Indian variant. The main reasons they are of concern is because they are more contagious, they're probably more aggressive. We have data that show at least 30% increased mortality with the British variant, although this is not conclusive. We have some preliminary data which shows the same for the Brazilian variant, higher mortality from these variant, but this is not conclusive. We have no peer-reviewed publication, but this is the feeling that we in the front line have. And it seems the same with the Indian variant. So those variants have been spread around the world and have been detected in many different countries, other than the one they were first described. And the other major importance is that they may not respond as well to current vaccines, but the majority of the vaccines currently in use have seen good responses for all those variants. The South African variant seems to be the higher evasion, but fortunately, the severe disease seems to be protected with the current vaccines. This is what happened in Manaus as an example that we should never be, disrespectful with the power of the virus, the COVID-19 virus. So we had a major disease outbreak last year with thousands of deaths. Yeah, Manaus is a very important city in the state of Amazonas, Brazil. And we had, thousands of patients, chaos in the healthcare system. And since things seems to be better after the major outbreak, and we had very low level of infection, and suddenly, in the beginning of this year, 2021, we had a very severe outbreak, which was clearly far worse than the first one. And the main reason could be related to the new variant and also the declining level of antibodies. We had studies with a seroprevalence of 70% of COVID-19 antibodies in Manaus population, but it came as a surprise because people thought that the concept of herd immunity was something that was starting to be, at least proven with one piece of the puzzle with the Manaus experience, but it was not true. So as we could see, there are many possible reasons related to these. Of course, none of this is conclusive, but this is to show that we need to focus and understand the virus very well. It's very important, the pathophysiology of COVID-19, so that it can give the best treatments available and understand how to give them, when to give them, which is the best profile of patients to receive them. So COVID-19 is different from any other viral respiratory illness. When you talk about COVID, you see a lot of different phases, and the patients can progress differently, probably related to the viral load they receive and also the immune response of the host. So you have clearly a very stage 1 disease, which have the viremia, mild constitutional symptoms, dry cough, diarrhea. 14% of the patients go to the pulmonary phase with hypoxemia, which is the main feature of COVID-19, because it's very important to understand that the breathlessness or dyspnea is not so common in this disease. We have a study that shows that among the patients with hypoxemia, only 19% had the feeling of breathlessness. So it's more common to see the high respiratory drive, the higher respiratory effort, then you have the patient tell you the sensation that has dyspnea. So it's very important that COVID-19 in those patients who progress to the stage 2 disease, as we can put it in a way to be, to understand more, a little bit better the disease, is a patient who has hypoxia, as defined by PaO2 and fractional inspired oxygen less than 300, and the chest image abnormalities, and 55% of these patients can progress to critical disease. Immunothrombosis is a key mechanism in COVID-19. This is a publication from Nature. And you know that the immunothrombosis is one of the mechanisms of defense against pathogens, that the inflammation and the coagulation can limit the pathogen, because you can, create an environment that you can block the spread of the pathogen. And in COVID-19, it's very clear that those patients who have unchecked viral replication, they probably have some kind of immune defect that allows the virus to replicate, probably related to the interferon response. And this way you can activate the coagulation cascade. There are other pathways in which this can happen. So the neutrophil is a very important cell in the severe stages of COVID-19, and the release of the NETs. It's very clear that the NETs that the neutrophils release, it's a common defense mechanism, but in the pathophysiology is related to the increase in inflammation, the activation of the coagulation cascade. And also the complement system is another way in which the coagulation can be increased in COVID. And the role of the endothelial cells is very important, because there are many studies showing that COVID-19 can infect directly those cells, and also that the inflammation related to the disease can also activate the cytokines, the endothelial cells. So any endotheliopathy can be the unifying mechanism for the pulmonary and the systemic manifestations of COVID-19. So this is another important way to understand that we have a mild disease, the virus comes to the lungs, and COVID-19, and there is a very high viral replication, even the incubation period. And the virus enters the airways and infects the alveolar type 2 cells via the AC2 receptor. And in the majority of patients that have a good immune response can get rid of the virus. But when those 14% who progress to the stage of the disease, you have a lot of inflammation, and also the microthrombi that starts to be forming because of the cytokines, interleukin-6, the direct activation of the coagulation cascades, the endothelial cells, and the neutrophil start to come in and release the nets, and so you have this microthrombi. So part of the patients will go to this stage when you can see those patients on the ward with hypoxemia, and some patients can go to progress the disease to a more severe disease when you have higher inflammation, higher thrombi, as you can see here, inflammation of the endothelial cells, the endothelitis, and it's associated with many bad cardiovascular outcomes like stroke, like myocardial infarction that can happen in those patients, and the systemic repercussions related to the coagulation, activation of the coagulation cascade. So in those severe patients, you see a higher risk of venous thromboembolism and the endothelial damage, as I told you, is the hallmark that can link the pulmonary and systemic manifestations of COVID-19. The pulmonary pathophysiologist, as I told you, you have this situation when there is a particular phenotype related to the COVID-19 pulmonary disease, which is very distinct from other viral respiratory illness. And you have patients who at the beginning have no problem whatsoever with lung compliance, but you have this hypoxia that comes from the inflammation and probably because of the dead space related to the microthrombi that is triggered by the virus. So there are Brazilian researchers who tell us that COVID-19 is probably the first viral thrombotic fever. So this is what should have in mind. So this is the alveoli, is normal, and when the disease progresses, the hypoxemia is related to the inflammation related to the microthrombi and the maladaptive immune response, and the hypoxia, which progresses, is the main mechanism by which the patient can, can go straight to death. So this is very important that we can understand this and act both on the inflammation and the coagulation cascade. The severe COVID pneumonia can progress to a situation just like on this patient. Is a New York patient, 20-year-old, who needed transplantation because of COVID-19. And the surgeon told that this was the most damaged lung that he has faced in his entire career. And so you should be very focused to avoid any patient to progress to this stage of the disease. From the beginning, the autopsy studies show that in those patients, there are a lot of thrombi, both macrothrombi and also microthrombi. In this patient, for example, you have a cor pulmonale that happened on this patient and probably was missed when he was being treated on the ICU. So it's very difficult to give a pulmonary embolism diagnosis in a COVID-19 patient because the patient is intubated or because the patient has on a severe stage feeling the dyspnea. So we need to be very focused, and whenever we think about thromboembolism, we should have the resources available and use them, just like the bedside echo that you could, for example, see a right heart strain on this case, looking for a thromboembolism with the scanning of the active surge of the DVT. Actually, we don't have studies that tell us that this strategy can give necessarily better result, but it's a very common sense, idea that we should non-invasively search for thromboembolism on those patients, primarily on the most severe patients, so that we can start the full anticoagulation. So it's very important that you understand that it's a very important hallmark of the disease, and to give you better care, we need to pay a lot of attention to this. So the pulmonary pathologies, as I told you, we have the patchy inflammation seen on the lungs, we have the thrombi, and there's also infection of COVID on the trachea. The tracheobronchial inflammation is very common in those patients. It was something that was not seen before, at least not being well studied. We don't know exactly how to interpret those findings, but it's very important to understand there is a tracheobronchial inflammation, and there's also this patchy inflammation. The thromboembolism is widespread. It can happen in any major vein on the body. There's also in the microcirculation. This is another study showing this, the thrombi, microthrombi, and also the patchy inflammation. This is a Brazilian study who was done with microbiopsies, the ultrasound guided microbiopsies, and show also a lot of microthrombi. This is a very important study for New England Journal of Medicine that compared COVID-19 pathology to H1N1, and the hallmarks appear this very often in many of those studies. So you have a lot of endothelitis, you have neoangiogenesis, which is related to the vascular damage that is inflicted by COVID-19. The inflammation in the lung is not different from other ARDS causes, but the hallmark of the destruction that you see here, this is a normal, and lung, this is the COVID-19 lung, the angiogenesis feature, and also the endothelial inflammation. So this is the one, thrombosis is widespread. This is a case in had of major thrombosis in the liver. And these pathology study, we can see very clearly all those major actors. You have the COVID-19, you have the endothelial cell with COVID spike protein closely, you have the microthrombi, you have those cytokines, interleukin Cs, you have TNF, we have chemokines, and we have the neutrophil, which is a very important cell for this disease with the release of NET, I have shown you before. So all those major actors are found in all those pathological studies for COVID-19. So what I can tell you since the beginning, we can understand it's a virus that causes a wide spectrum of disease in humans. And in the severe forms of the disease, we have very clear an inflammatory thrombotic disease. This is the way I think it's better to understand the pathophysiology of COVID-19. This is a very interesting case report, and we have the CT scan that is used as in some hospitals. And you can see in this energy CT scan, we have the characteristic path inflammation in COVID-19, also a hypoperfusion. So this is what probably is related to the most important aspect of COVID-19 pathophysiology. We have a very important inflammation on the lung, and also a very important thrombotic disease with dead space, and the shunt that happens probably is the way the respiratory failure happens in those patients. This is very important to understand, as it has implications for the management of the severe illness. All the doctors leading to studying COVID-19 need to understand this very clearly. So the laboratory finds associated with worse prognosis in COVID-19 are very well known. We have the worsening of lymphopenia, and this is what I can understand that is one of the most important in my experience. When you see low lymphocytes, very low lymphocytes is associated with worse prognosis, and when the patient recovers, I see the improvement of lymphocytes. The dimer, increase the dimers very since the beginning associated with worse prognosis. And of course, the increase in the association of renal failure is a very bad prognostic marker. So these are the classic findings of the laboratory findings associated with bad prognosis: the lymphopenia, the high inflammatory markers, CRP, ferritin, the high dimer, the high creatinine phosphokinase. And I have seen some patients with hypernatremia, and it usually is a refractory hypernatremia. And some authors have also published some crazy reports on this finding, and I have seen on the second wave, it could be a coincidence because it was worse than the first, the number of patients were higher, but I have seen hypernatremia on those patients. It's usually refractory, it's associated with a bad prognosis. So when you see hypernatremia, those patients should pay a lot of attention and understand that it's completely different from the hypernatremia that you see in other common hospitalized patients. So we need to pay attention to this finding, and we need to study more to see how to better manage this situation. So the severity classification, you understand that the 80% is a mild disease, and those severe disease has the associated just CT findings with 50% or more spread on the lungs, and the critical disease, the patient with a respiratory failure, which needs to use high flow nasal catheter, non-invasive ventilation, those who have shock, multi-organ dysfunction, and the overall mortality is 2.3%. Patients, you don't see any mortality in patients who are not on severe disease. The mild COVID-19 treatment is well known. It's hydration, symptomatic treatment. We need to educate the patient that he needs to see a doctor whenever his oxygen level by a pulse oximeter is below 94%. Need to pay attention to red flags like cyanosis, tachycardia, onset of mental confusion. So this is the most important for the to teach the patient where he should go to the hospital, and he should be very conscious that the disease has the possibility to extend for weeks, and he should pay attention primarily from the 5th day up to the 12th day of disease. Most of the patients, in my experience, get worse on the 8th to the 12th day. It could be different from this new variant. It seems to be from the 5th day or on, but we need to teach to the patient that after the first week, he should be very careful to pay attention to the red flags so that he can go to the hospital as soon as possible. So for the early treatment, we have many studies, and none of them is conclusive. When you look at the outcome of progression of disease, so we have a Brazilian study with nitazoxanide, which show responses in the symptoms and the viral load measured by the swab, presence by swab, but you need to understand this is a preliminary data, and we don't have any evidence of that this can block the progression of the disease, which would be the most important treatment, the most important outcome. The early treatment of COVID-19 with hydroxychloroquine and azithromycin is the same. We have many studies showing improvement symptoms, improvement of viral load, but we have no conclusive data as to the progression of disease, which would be the most important outcome on those patients. So unfortunately, they are not very well proven early treatment for COVID-19. Ivermectin is the same. So all of those treatments seem to be efficacious for one domain, like symptoms or viral load, but they cannot stop the progression of disease, which would be the most important outcome. Colchicine is a very interesting medication that has been studied in the Cochrane major study, which is initiative from the Montreal group, and it's a very large study, 4,000 patients. It's multinational, multi-centric study, and it has shown that it could the use of colchicine on this dose 0.5 twice daily for 3 days, followed by 0.5 for 27 days, could reduce hospitalizations, could reduce death. But this is not being published in a peer-reviewed study. There's a lot of methodological discussion on these, because the composite outcomes can be very biased. So we don't have it as for now published in a peer-reviewed journal. And although the excitement of the lead investigator that could be an early treatment for COVID-19, it has not been widely adopted around the world, because we don't have the study published in a peer review, and there are a lot of criticism on the methodological aspects of this. But when you study all of those different medications, this is the most robust study that we have for a medication in this situation of early treatment, showing that it can be promising at least. So we're going to wait for this, the publication of the trials. So the microview treatment, you have a small evidence for colchicine. You have evidence of harm to corticosteroids. So it is very important because in many countries around the world, in Brazil, for example, there are many doctors who are using steroids. In the beginning on the first phase of the disease, we know that this is very harmful, not only from the recovery study, but also from other epidemiological data that show that patients who are using steroids had a worse outcome for the disease. So we should not use. And if you have some patient who is using steroids for any reason, it's possible for this patient to taper the dose. I think it would be a very interesting recommendation. If the clinical reason he's using steroids, you can reduce the dose during this time of infection, because you know we cannot just withdraw suddenly because of the concerns of adrenal failure, secondary adrenal failure. So you can at least, if the clinical situation allows, to reduce the dose of steroids if he's a chronic user. You should tell the patient about the red flags and seek emergency care. And if you are willing to prescribe an early treatment medication, it's very important that the shared decision-making with the patient, because we have no proven in the terms of outcome of the disease, but it could reduce symptoms. It could at least reduce contagion if it actually reduces the viral load, but those outcomes have not been proven. The hospitalization criteria for COVID-19 is very straightforward. Those patients with respiratory distress should be hospitalized. We should be very careful with what I told you on the beginning of this lecture, that the dyspnea is not so common, is not proportional to the degree of hypoxemia of this patient. So the respiratory drive should be emphasized for COVID-19 patients. And the saturation with pulse oximeter less than 93%, 94% in room air. And on all those patients who have a CT scan and at least 50% involvement of the lung, or if it has a serious CT scan and it has an increase of 30%. We learned this from the beginning of the pandemic in China, when many patients had serious CT scans. You should not order a CT scan on the first 3 days of the disease. If you feel that the patient is getting worse, you can order the fourth day on to see if how much lung involvement you have. So when you have this in mind, you can say when you should hospitalize a patient. The hospital management, you have the supportive therapy and also the medication treatment related to the COVID-19 disease. It's very important that all doctors understand how to manage the oxygen therapy with the many devices, and understand, and those who are not well trained should be instructed on how to use the devices, and understand that for the severe disease you can use the non-invasive ventilation and also the nasal high flow oxygen, because although they are not very widely available in many parts of the world, it's very important that we can use this, because in the beginning of the pandemic there was very high concerns about the aerosols generated by those devices, and many patients went from this to the intubation because many hospitals were very worried about using those strategies. But this is, in my opinion, today very clear that you should use this when you have available, and it's part of the strategies to better manage the disease, to have developed resources for oxygen therapy. And you should train all the healthcare personnel how to use them, and those involved directly on the care of the patient, respiratory physical therapists, nurses, doctors, should be their protective equipment for the best quality to make this practice very safe for all the healthcare personnel, and we should use these in very standardized way for those COVID-19 patients. It's very important the awake prone positioning for those patients. This is a patient with the awake prone, something that we learn from the disease. We have studies who show, just like this one, the prone COVID study, that the awake prone is feasible, it is cheap, and so every hospital dealing with COVID-19 patients should have in place protocols for the prone positioning, awake prone positioning. And there are studies evaluating that if the combination of the awake prone positioning with the non-invasive ventilation, for example, together can give better results for those patients. So it's very important that you understand that it's safe, that it is feasible, and there are many articles proving that it is very worthy in COVID-19 patients. The non-invasive ventilations, I told you, with mask or helmet should be used in those patients. We should not have concerns about authorization, and we should do everything we can with negative pressure rooms and better protective equipment to ensure that the patients can have access to this. We have many studies, although they are not conclusive, that show that at least 50% of the patients with these non-invasive ventilations can avoid intubation, just as the high flow nasal oxygen has shown on the intensive care field to avoid the use of avoid the mechanical ventilation in a substantial number of patients. This is a very interesting study comparing the helmet non-invasive ventilation to the high flow nasal oxygen. It has shown to be non-inferior. So it's very important that we can advance in our understanding of how those devices can be used and put them in proper use with the training of the medical team, the physical therapy team, of the healthcare personnel to use them. This is a study for high flow nasal oxygen in COVID-19 patients, showing similar results to other respiratory failure situations, and when you use this high flow. So we need to put in place whenever possible. Well, let's talk about the medications. It's very important to understand the clinical judgment should be in place, and we should make better use of our clinical judgment, and evidence-based measures should be married, should be together, and to make better decisions for patients. When you are seeing COVID-19 patients, it's very important to understand the importance of antibiotics in COVID-19. So there are many studies who have proven that the co-infection is 3.5%. So at admission, there is no need to use antibiotics. And the secondary infection after presentation can occur in up to 15% of patients. And of course, it's higher when the patient is on the ICU, on mechanical ventilation. There are many studies who show that the secondary infections can be at least 50% more in COVID-19 patients. And it's related to many different factors. I have the experience to see that the lymphopenic patients tend to have more infections. So the severity of the disease related to lymphopenia also could be partly to the increased infection rate, and should pay a lot of attention. So what we can understand from this is that we should not give antibiotics for patients at admission, and we should look for secondary infections in those patients after presentation, and you should cover whenever possible. And you should not see the high antibiotic prescribing as we have many studies showing at least 7 to 1%. In Brazil, I can tell you it's more than 100% in many hospitals, the use of antibiotics, because the doctor cannot tell the difference if the patient has a bacterial pneumonia or not. But this should be, abandoned, and because the prescribing of the antibiotics can lead to selection of multi-resistant bacteria and can make the outcomes of those patients worse and the society worse, because those germs can be spread and can be a very bad deal for the society. So when you should consider antibiotics, when you have COVID-19 patient with low infiltrate who's immunocompromised, because the immunocompromised patients cannot, mount an immune response, and you cannot see sometimes the infiltrate because they don't have cells. Those patients who are a lot dehydrated the same way, those patients on sepsis, I think is a very important point to consider antibiotics because they are severe. And those patients who are improving and have a sudden worsening, we should consider secondary infection. When not to consider, when is a COVID-19 classical patient, because the co-infection rate is very similar, except for the immunocompromised, because they cannot show the typical signs of secondary infections. So this is how you could guide your antibiotic therapy. And after the hospital admission, you should pay a lot of attention, as I told you, because primarily on the ICU patients, the secondary infection rate is very high. So of every patient with new or recurrent fever, increasing procalcitonin, those patients who has change in sputum or has a start on sputum, new leukocytosis, new imaging findings, and new or increasing oxygen needs, you should think about secondary infection, and never forget about ordering cultures before antibiotic therapy, and also guide according to local protocols and with in contact with infectious disease specialist team. I should remember you about the COVID-19 pulmonary aspergillosis. It's a very well-described complication in those patients. And the aspergillosis in COVID-19 patients is different from the other settings in internal medicine, when the common risk factors like diabetes, like in neutropenia, are not commonly seen. So you must have a high degree of suspicion, and the halo sign can be found on some patients. So of the patients who have a great worsening of the disease, you should be very cautious about the possibility of pulmonary aspergillosis, and as you can direct therapy with proper antifungal therapy. So we need to, every doctor who's dealing with COVID-19 should study about pulmonary aspergillosis. Let's talk about medication therapy. You have the antivirals, the monoclonal antibodies, immunomodulatory therapy, anticoagulation. For the antiviral therapy, many drugs have been tried. This is the Solidarity study, and you have no effect of remdesivir, lopinavir, hydroxychloroquine, and interferon. So probably because the patient is in a different stage of the disease, the viral replication is not an important factor. And possibly those antiviral medications have a window of opportunity that has not been shown in many studies to be met. We have for the remdesivir at least one randomized trial who showed 4 days of hospitalization reduction, and this was the basis for remdesivir approval in the United States. And remdesivir was also approved in Brazil, but is not up to this week available for use, because there is they're following the process here. But I think that this drug is very controversial. There are many open questions around the efficacy of remdesivir. It does not work in patients of mechanical ventilation. So it's a very expensive drug. I think that probably it could be of good use in immunocompromised patients who can have an extended viral replication. And those who have a good experience with remdesivir say the main reason is the patient seems to improve faster, and this could lead to the reduction of hospitalization. But it's a very controversial disease. In my opinion, I would use in any patient who meets the criteria, which is the patient who is admitted with on the ward, was not on mechanical ventilation. And I would use those immunocompromised for sure, because I think that the viral application could be happening. We don't know if it works in combination with dexamethasone, for example. We don't know. There is a study with baricitinib that show a little bit of improvement with baricitinib, at least 1 day more of hospitalization reduction, but it's a very controversial drug, and you should use according to your local protocols and discussion with the infectious disease team, and using according to protocol. Hydroxychloroquine and azithromycin don't work for hospitalized patients. There are many randomized studies, the recovery and also the Brazilian study, who show no efficacy either for hydroxychloroquine or for the combination with hydroxychloroquine and azithromycin. The monoclonal antibodies are very important development in infectious disease, and they have shown a very important efficacy on patients who are not hospitalized. So those patients with this passive immunization can, have a great benefit with the reduction on the progression of the disease. You should not be using hospitalized patients because the results were not good. So there was no good outcome in the hospitalized patients, but it's a very important development, primarily for those immunocompromised patients who cannot, produce enough neutralizing antibodies. This is a form of passive immunization. So I think there is a role for this. I think the improvement in the delivery from the IV to the subcutaneous can improve the adherence to this, and also as the price falls, it could improve the adherence for the use, but it's an important strategy for those patients who have high risk of progression, and you can, have the availability and use for those patients. I have seen patients, for example, in the hospital that have transplanted patients who acquired COVID-19 in their hospital stay and had a very bad progression for a mechanical ventilation, months of hospitalization and, lung fibrosis. So in these patients, we have this available. And as soon as we knew he had COVID, you could start these monoclonal antibodies. We have studies with passive immunization from antibodies, horse antibodies. In Brazil, there are studies undergoing, in Latin America as well. So if these horse antibodies can show as much efficacy as the monoclonal antibodies with 1/3 of the price or 1/10 of the price, they can replace these monoclonal antibodies because of because they don't have the barrier of the price, of course, and they can be more available. But it's very important to understand that they are very highly efficacious for this situation to avoid the progression of the disease. So we need to understand we have this on the on our arsenal, or our weaponry against COVID-19. The convalescent plasma has been promising in the beginning, but the randomized trial show it is not useful for COVID-19. So we don't need to be worried about this topic anymore, because we've shown that it does not work in very carefully done randomized trials. The immunomodulation is the most important aspect of for COVID-19. The steroids on the beginning, there was a lot about bad mouth about corticosteroids when many authors told us that the experience was bad with other respiratory viral illnesses, and also in the previous respiratory coronavirus disease with MERS and SARS. So there is this publication Lancet so that you should not use it. But fortunately, there are many previous articles who have been showing benefit for the use of corticosteroids. The retrospective retrospective study in China showing an efficacy in mortality with methylprednisolone. But of course, this was a retrospective study. And finally, the British did a very important study using dexamethasone, which is the recovery trial, showed that 6 milligrams, a very small dose, for up to 10 days, led to 25% reduction in mortality for patients who need oxygen and 30% of patients on mechanical ventilation. This was a landmark study who when it was published, showed the first drug who could be able to have an important outcome in COVID-19. And it was really a landmark study, and the use of steroids started to be commonplace in any any hospital dealing with COVID-19. This is a Brazilian study who a Codex study. It studied a higher dose of dexamethasone for COVID-19. It has been stopped earlier because the publication of the recovery trial could not have a placebo arm anymore, so it was abandoned. The many trials were stopped because of that, the publication of the recovery, but it showed that a higher dose was also effective in those patients with no increased safety problems, so no increased infections. And this is one important question in terms of steroid that we're going to talk a little bit about, which is the right dose, which steroid, which duration. So there is a meta-analysis who showed this, that many different corticosteroids can have an efficacy in COVID-19. The question about which steroid has not been definitely answered. We have this study who compare methylprednisolone with dexamethasone, because there are many doctors who think that methylprednisolone can have a better lung penetration and could have better efficacy as compared to other steroids. And this study, they showed that methylprednisolone was better than dexamethasone. So this was a positive study for methylprednisolone, but it used higher dose of methylprednisolone compared with the small dose of dexamethasone. So this, in my opinion, severely compromised the interpretation of this study. And there are other studies who show no difference between those two steroids, which are very small, of course, but we have no answer as to which steroid should be used. Which dose? There are many doctors who deal with COVID-19 who think that as the dexamethasone 6 milligram and equivalent is a very low dose for COVID-19, higher dose could do better. So this was a retrospective study in Spain who showed clearly that the high dose corticosteroid, which for then was at least 120 milligrams of methylprednisolone or equivalent, was associated with better survival in those patients. It's a retrospective study, but is one who tells us higher dose could be better. And also, all the studies in the medical literature have been showing consistently that higher doses could be more efficacious in COVID-19 than lower doses. So in my experience, patients who have higher inflammation, who are obese, or of course, who are not responding to the low dose or are progressing very rapid disease, should try the higher dose. We don't know how much higher it should be, but in my experience, at least 20 milligrams or the equivalent of dexamethasone. And there are some cases in which both therapy with at least 500 milligram methylprednisolone or equivalent can be used in those highly inflamed patients with better results. The duration of therapy for the recovery trial was 10 days. And also, there are many other authors who think that in those patients who are on mechanical ventilation, you could use for a longer time, because the steroid could have good results for the lung fibrosis or other outcomes. So this is not a definite answer. So this is just expert opinion that you should use for a longer duration in some patients that who are more severe, those who are mechanical ventilations, because we have a lot of literature on ARDS with dexamethasone for up to longer time of use with improvement. So this is up to any doctor decide. So this is the list, the minimum dose who should be used, which is equivalent to what was used in the recovery trial. But there is growing evidence, and I think you should be very, very, it should be on your mind that when you see patients with higher inflammation, you can use a higher dose. So we don't have any conclusions about which steroid. As I told you, dexamethasone is cheaper, has a power inflammatory, has an auto taper because it has a longer half-life. And some doctors, when the patient is in shock state, switch to hydrocortisone because there are the literature who show that hydrocortisone could be useful on patients with shock states. So these are the considerations for the steroids. We need to understand more about the higher doses being better than the lower dose. There are many hints on the literature who show you this. Also the duration, but I can tell you for the patients who are discharged from the ICU, who have a very can keep the need for oxygen for a longer duration. I think a new cycle of steroids should be warranted on those patients, and I have seen a lot of improvement. So I have patients who have been discharged from the ICU, who have been 10 days on the ward and cannot, withdraw for the oxygen. So they give you higher dose of steroid for a shorter time, and possibly because of the fibrosis or the process, inflammatory process happening that is different from the beginning. He's no longer in danger. I think that the improvement is great, but this is not based on scientific studies. We need to study specifically for the situation, but this is a based on clinical judgment. Tocilizumab, we have since the beginning of the pandemic, tocilizumab has been tried. This is a trial in China who show a response for those patients. This is before tocilizumab, and this is after. You see an improvement on the imaging findings. And many randomized trials started since then with conflicting results. This is one major retrospective trial with a US database who show an improvement in mortality. And you have trials just like the Brazilian study. It's a small study showing no effect on mortality and could even lead to increased mortality. This very small study, this trial was impacted, who show benefit for those patients. So the many tocilizumab trials were just like that, different patients studied different doses, and the use of steroid was very different because the timeline of those studies was very spread along the pandemic timeline, and the steroids started being used and from June on. And so those studies who continued from this time period or who were started on this time period, the patient had higher use of steroids. So many trials were conflicting, just like the COVACTA study. And there were some later studies who were positive, just like the HEMAP-CAP, which have a higher number of patients, and was the first study, well-done study, randomized, who showed a good outcome with tocilizumab, a reduction in around 24% of mortality. And we see that 90% of the patients were using steroids. And the recovery trial, which has been recently published on the Lancet, was a very large trial for 1,000 patients. And we see a 50% reduction in mortality in patients on mechanical ventilation. And this was the landmark study who showed that tocilizumab could be used for COVID-19, and there were no important safety signals because there were many concerns with infections. There were many concerns um, with intestinal perforation and other possible complications. But we need to understand the importance of the recovery trial, and not only for the dexamethasone, but also for tocilizumab. The population study on the recovery trial was different from the REMAP-CAP. The REMAP-CAP was the previous study I showed. They studied patients that were on the ICU. In the recovery trial, patients on the ward with at least a CRP of 75. So the conflicting results, as I told you before, was because of all of those different aspects of the patients studied, the timeline on the pandemic. So what we can understand is that monotherapy with tocilizumab does not work. The effect is additive or synergistic with the corticosteroids. And the infection none of those studies show increased infection with tocilizumab. So we can understand that in real world settings, in those patients who seem to have more risk factors, it could be a little bit different, but we have seen no increase in infection in the tocilizumab studies. The cost is another concern because it's a very expensive drug, but it could be cost effective if you can take the patient away from the ICU or avoid going to the ICU in first place, because the ICU is very expensive, at least in Brazil. 2 days of ICU. If you save 2 days of ICU, the drug is already cost effective. We need, a very well-done study to prove the cost effectiveness of this, but I think that because of the benefits for the patients, probably they are tocilizumab is cost effective as well. And tocilizumab, the summary is probably it has an additive or synergistic effect with steroids, and there is another question that arises: that what is tocilizumab giving the patient? Is tocilizumab covering the degree of steroid that was lower? And if the steroid dose was higher, you would not need tocilizumab. Or the blocking of interleukin-6 is crucial for a subgroup of COVID-19 patients, because interleukin-6 can have a very important role in the lung fibrosis. So if you block interleukin-6, you can have an improvement fibrosis. It has been approved for scleroderma lung disease in rheumatology recently, tocilizumab. So we don't know if the pleiotropic effects of interleukin-6 on the pathology of COVID-19 and other disease, the benefit comes from blocking those pleiotropic effects. And we don't know if it's should be used in later stage of the disease above 24 hours of the ICU, or if the lower doses can be as effective as a higher dose. But it's very clear to me that, as many different guidelines tell us, the best patients seems to be those patients who is in need of ICU and who has at least one high inflammatory marker, just like CRP over 75 as a study on recovery trial, or high lactate dehydrogenate, high ferritin. I think ferritin is a very important marker for COVID-19. Those patients who have ferritin over 500 are clearly on severe disease. So all those markers can be used to tell us that this patient is on a severe condition and has at least one of those high inflammation markers that tell us this is a more severe patient. So all the guidelines tend to put the best patient for tocilizumab, the hospitalized patient in need of ICU care. Different for the recovery trial, who show benefit even for the ward patients. I think the common sense that it should be used on this population. Pay attention to patients who have uncontrolled bacterial infection or even viral infection other than COVID, who have higher transaminase levels and higher risk of intestinal perforation, because we know that tocilizumab can contribute to that. But we should strongly consider tocilizumab for the patients who are on the need of ICU. I think in my experience, it works better for patients when they are on need of high flow nasal oxygen or non-invasive ventilation and has at least one high inflammatory marker. This is a case that I had the opportunity to use tocilizumab in the beginning of the pandemic last year. And after one day of the ICU admission, this patient was at home and worsened very fast. Went to the hospital for the ICU. I studied tocilizumab on the second day. It was, of course, at the time was not in a clinical study because there were no study recruiting at this hospital. So we studied this in this patient, and it was very effective. The X-ray improved very rapidly. 12 hours later, there was an improvement, and the patient fared very well, although it was a high-risk patient, 82-year-old, hypertension and obese. This is the CT scan for this patient, the hospital admission. This is the CT scan after 12 days of hospital admission. So I think tocilizumab has an important role in COVID-19, and it should be strongly considered as there is important scientific articles backing up its use. But we need to understand which is the best patient and to optimize the care of COVID or COVID-19, and to answer if it is giving more immunosuppression because the steroid doses are lower than they should be because of the recovery, who standardizing lower doses for COVID-19, or if it really has important effects. What you can understand from the pathophysiology for COVID-19 is that the cytokine storm is a little bit controversial. You understand there's an important inflammatory reaction. We don't know if it amounts to the level of the cytokine storm that you see in other disease states related to the cytokine storm, just like the macrophage activation syndrome, or the cytokine release syndrome related to the CAR T-cell infusion. But it's very clear that there is an immune dysregulation, a high inflammatory profiling of those patients, and possibly the blocking with tocilizumab could be useful for a subset of patients who have these high inflammatory reaction and are more severe. The anticoagulation in COVID-19 is a very important topic. We understand that the mortality is higher in those high D-dimer levels since the beginning of the pandemic. And the use of anticoagulant, even in retrospective studies, show reduction in mortality. So the main question is, which is the dose you should use? We understand that every COVID-19 patient should use prophylactic dose anticoagulation with low molecular weight heparin. And there is even studies from an in vitro study who showed that a molecular weight beyond the anticoagulation could happen the inflammation as well. So those who have no contraindication, who have a higher than 30 creatinine clearance, can use low molecular weight heparin. And so for the prophylactic dose, there is no doubt at all that every patient should use or heparin when the creatinine clearance is less than 30. The question about the dosing, if you should use intermediate dose for those who are higher risk, for example, patients who are obese or patients who have other clinical risk factors for thromboembolism, it's up to local protocols in terms of prophylactic dose. What you understand that there is a study recently published who show that the intermediate dose or the prophylactic dose for patients in the ICU, there was no difference. But there is a major study ongoing who is about to be finished, who has been studying in a large cohort of patients, the prophylactic versus full anticoagulation in COVID-19 patients. in different sets on the ward, and on the ICU. And they have reported that for patients on the ward, the full anticoagulation is associated with benefits on COVID-19 patients. It has not been published. It's just a new release for a press release for those group of investigations, and has shown that in the ICU patient there was no difference in mortality and could be associated with a higher risk of bleeding. So it's possible really that on the timeline of the disease, there is a window of opportunity to use full dose anticoagulation in COVID-19 patients when they are on the ward. We are eagerly awaiting for the publication of these results. We have a preprint publication for these results for the ICU patients, as we can see here. There was no defect for full anticoagulation in patients on the ICU from this group, but they report that the preliminary analysis is that it is a positive result for the ward patients. So we should wait, and the possible explanations that there is a timeline when the thrombus is forming, and that you should not miss this opportunity. But we are waiting. There are some hospitals who are allowing doctors to talk with the patients about the benefits and risks of full anticoagulations for the ward patients, and should be very carefully discussed until we have the publication findings. I should remember that every patient who is in full anticoagulation for other reasons, like atrial fibrillation, when is admitted with COVID-19, should be switched to the low molecular weight heparin, full anticoagulation. So if he's using for a new anticoagulant, when he's admitted with COVID-19, should be switched to full anticoagulation with low molecular weight heparin, or eventually on fractional heparin if he has a lower creatinine clearance. Pay attention to pulmonary embolisms in COVID-19 patients, and all those patients with higher dimer values, patients with classical symptoms, but it's very difficult to give this diagnosis. So as I told you, I show you a necropsy finding from a patient from the Louisiana autopsy studies had a cor pulmonale. So you should pay attention, use bedside echo, screen for DVT with the ultrasound, and should pay attention. And all those patients who are suddenly worsening, who are improving and suddenly worsening, have difficult oxygen therapy weaning. I have many patients after discharge from the ICU and the weaning for oxygen, the withdrawal of oxygen very difficult. So in those patients, the pulmonary embolism could happen could happen at any time. So we should pay attention to this. So patients who are on more severe have higher prevalence of pulmonary embolism, and the patients improving on the inflammation and improving the D-dimer. So you should pay attention to these. There is also an important thing that, for my experience, those who are on the ICU and the prone positioning does not improve the oxygen levels. Is an important hint that it could be happening and should be very aggressive. As I told you, the full anticoagulation has a very important indication when you have a PE or a DVT, but it does not work on patients when you cannot prove this diagnosis. So it's very important to prove the ICU patients. In those patients, the treatment could, of this complication obviously can save the patient's life. It is a PE in a patient in our field hospital. We had a contrast CT scan on this field hospital. So we had many patients with severe COVID or with difficult oxygen weaning, and we found a very high prevalence, at least 30% of PE in those patients. Another topic important in the anticoagulations, the extended prophylaxis in the COVID-19. We have seen this topic in clinical patients with the some new anticoagulants, like was studied in the Mariner study. But we understand that the extended prophylaxis for those patients who have higher risk seems to be warranted. We have no conclusive evidence about this, but we understand that many patients who are discharged for COVID-19 are dying and are being readmitted. We have a press release for a study in Brazil. We have a study I'm going to show you a little bit later, and the veteran study who show a higher readmission rate and mortality for those patients, up to 27% of those patients. And many of those problems are related to the thromboembolism or arterioembolism. So I think that it could be a common sense to understand that if the patient has high risk and of thromboembolism and low risk of bleeding, you should consider. I use the IMPROVE score to make this decision, and I use the new oral anticoagulants as the first choice when I want to do the extended prophylaxis. But if the patient doesn't have money to buy, I think the anti-aggregation with acetylsalicylic acid could be an important alternative for those patients. And the field hospitals in Brazil, which or for the public health system, patients don't have money to buy the new oral anticoagulants I gave them when they had no contraindications, of course, 100 milligrams of acetylsalicylic acid. So it's very important to understand this. The IMPROVE score is validated for many clinical patients, and those who have a score +4 or a score +2 with twice the D-dimer level should be considered for extended prophylaxis. And those who have a higher score of bleeding, you should, wait if you give it this extended prophylaxis. But if the patient meets this criteria and does not meet this, you should consider using the extended prophylaxis for COVID-19. So this is the summary. Now you should use prophylactic heparin for everyone. The full anticoagulation, there is a major trial with a negative result for the ICU. There's another trial with a negative result for intermediate dose. Pay attention to PE or DVT in those patients and consider the active screening. It's uncertain if they can benefit toward patients, but there's a major trial who suggests this is possible via press release. We are uncertain if the new oral anticoagulants are better. We have a publication that is coming up that rivaroxaban for ward patients was associated with increased risk of bleeding and no benefit. So this contradicts the press release, but this was for the heparin, and this oral anticoagulant rivaroxaban was for is another study. So there is a difference in ward patients. So you have to wait a little bit to see the full results published for this major trial. And I think every patient should be considered for extended anticoagulation. Those who have higher risk as measured by IMPROVE score or PADUA score or whatever score you use routinely to decide about extended prophylaxis in clinical patients, and have a low risk of bleeding should, according to clinical judgment, decide about the shared decision-making with the patients. The discharge criteria, patient is clinically stable for at least 7 days. The majority of patients, of course, who are admitted will be over 7 days, but sometimes they can be admitted sooner, at least on the ward, and have no fever and no need for oxygen support. You should consider discharging. So this is the summary for the COVID-19 adult patient management. You should stratify the risk. So the age is a very classical risk, but it has been changed from the new wave of the pandemic, at least in Brazil. So the higher proportion of younger patients have been suffering with COVID-19 than on the first wave of the pandemic. Diabetes, immunosuppression in general. The use of the biological drugs for rheumatic disease patients doesn't seem to be, at least the majority of them, associated of higher risk for COVID-19 mortality, but in general, immunocompromised is a very important patient. Chronic pulmonary disease, hypertension, and obesity in pregnancy clearly are risk factors. In the laboratory, D-dimer, ferritin, CRP, DHL, troponin, lymphopenia, we should pay attention when they are higher. And when we have this and the clinical findings of rare respiratory effort or a CT scan with at least 50% lung involvement, you should choose the ward, and the patient has signs of higher degree of respiratory failure as measured by the use of axillary muscle, unstable hemodynamics, go to the ICU. Remember the oxygen, awake proning, prophylactic and anticoagulation for every patient with COVID-19, of course, who has no contraindications to some of those therapies. And you should start then on steroids, at least 6 milligrams of dexamethasone or equivalent. For all those needing oxygen, you should consider strongly higher dose. For patients who are in more severe states, because I think lower dose do not work well for those patients, or they are obese, should consider strongly. I use at least 20 milligrams of dexamethasone, but higher dose could be even better. So there are many doctors who work on the COVID-19 field who feel the same. And those patients who are in need of high flow nasal cannula, who are in need non-invasive ventilation, and has at least one high inflammatory marker, CRP, ferritin, DHL, who do not improve corticosteroid, you should consider tocilizumab strongly and pay attention to the exclusion criteria, who is the concurrent infection with bacteria, or patients who have high risk of intestinal perforation, has 5 times the level of alanine transaminase, and patients who have a severe neutropenia as well, or very severe thrombocytopenia. This is not so common in COVID, but we should mention it. So you should keep in mind the immunomodulatory therapy for the COVID-19 patients who are on oxygen at least. You should consider this. The full anticoagulation I have talked about already. Patients on an oral anticoagulants should switch low molecular weight to heparin. And you should be very suspicious for VTE and PE on those patients. Those who are more severe have higher risk, and patients who have a previous history, of course. So whenever feasible, prove it with CT or Doppler. But if you're very highly suspicious and you don't have that available, the patient is in a lower risk of bleeding, you can consider empirical full anticoagulation. But we need to understand that whenever possible, should prove it. This should be exception to the rule, of course, but you need to understand that you can save the patient's life. So you have a patient who's intubated, for example, does not improve on prone positioning. You have the bedside echo who's a right ventricular strain. This could be a good patient to use the full anticoagulation, but sometimes you don't have that available. You should have a very high suspicion. So this many algorithm is related to the pathophysiology. It's a virus that can trigger a serial inflammatory thrombotic disease. We need to understand that we need to give the right risk stratification, supportive therapy, immunomodulatory therapy, and the anticoagulation therapy. We need to understand that if we approach the right pathophysiology of the disease, we can have better results for those patients. See, this is a 5-minute summary that I have published about this. I'm going to give you the link to have access to this. So we need to understand that you have all this together and need to make the decisions about the immunomodulatory therapy and the full anticoagulation. Pay attention to the long COVID. Now, as I told you, 27% of COVID patients in this study were readmitted or died. It's a veteran-based study, a fair system-based study. So you need to understand that the post-acute COVID-19 care is very important. And also or the post-acute COVID syndrome is very important to be for us to pay attention. And those patients who are discharged, our work should continue. And I think most likely many of those complications are related to the thrombotic risk that is increasing in those patients, because when you are studying COVID-19, you need to understand that it's a virus related to a very thrombophilic profile. And we need to follow those patients for the long COVID, because weeks after the disease, we can have persistent symptoms in many different domains. Lung, central nervous system, you should put in place clinics to follow those patients. Well, let's go. Conclusions. It's an inflammatory thrombotic disease with high morbidity and mortality. The control of inflammatory access has an impact on reducing mortality and outcomes. The clinical judgment is very important, together with discuss available evidence, and should be applied in decision-making. The acknowledgements I would like to do for the hospitals that I have the opportunity to work. This is the field hospital, 1,000 patients. We had this picture here with this patient. The field hospitals of Ibirapuera and Barrados I work, the university that I have completed my training, the hospitals, private hospitals in Brazil where I work, and I had a very important experience of COVID-19. This is my staff in the field hospitals. I cherish them a lot. Were hard times and continue to be, but we could keep our faith. This is a tribute to all the healthcare personnel who died in the battle against COVID-19. So this is a tribute to those nurses and doctors and healthcare personnel. And in one of those pictures, one of those people who have died, it's from Mexico, this picture here. And I like to pray a lot for more than 3 million victims of COVID-19. I have lost an aunt, a very close aunt with COVID-19. I could not save her. It's very sad. The whole world has suffering the impact of this disease. But with resilience and faith and knowledge and science, we're going to win this. Thank you very much. This is my email, and I'll be very happy if I can answer any questions related to COVID-19. I have acquired a great experience, and I try on this lecture to put together some of the major developments on the disease treatment and some experience that I have acquired on the many of those patients. And it's a very high privilege and honor to be able to present this to you. Thank you very much.